Neurology quiz number 107. Discuss medications and other measures used for prophylactic treatment of migraine. Part 1 of 2. Prophylactic migraine treatment is intended to reduce frequency and severity of attacks, render acute treatment more effective, decrease headache-related disability, and improve headache-related quality of life. Indications for preventive therapy are mostly based on expert opinion and include the following. Number 1, 2 or more migraine attacks per month with severe disability, 4 or more migraine attacks per month with some disability, or 6 or more migraine attacks per month with no disability. Disability can be defined by scores that indicate moderate or severe disability on the Migraine Disability Assessment or MIDAS questionnaire or Headache Impact Test or HIT6 questionnaire. Number 2, acute migraine treatment is ineffective or contraindicated. Number 3, there is associated medication overuse headache. Number 4, highly disabling migraine attacks such as hemiplegic migraine or migraine with brainstem aura. And number 5, patient preference. Migraine preventive medications can be divided into two major groups, non-specific oral medications and migraine-specific medications. Prophylactic medications in migraine can be non-specific oral medications. These include antidepressant drugs such as amitriptyline and venlafaxine, antihypertensive drugs such as propranolol, metoprolol, atenolol, candesartan, and lisinopril, anti-seizure drugs such as sodium valproate, topiramate, and gabapentin, NMDA antagonists such as memantine, and nutraceuticals such as magnesium, riboflavin, and coenzyme Q10. The second group of prophylactic medications in migraine includes migraine-specific medications. Number 1 is CGRP antagonists. These can be monoclonal antibodies such as erenumab, fremanezumab, galcanezumab, and eptinezumab, or they can be small molecules or gepants such as atogepant and rimegepant. Number 2, Botulinum toxin A. Number 3, triptans used for short-term prevention of menstrually related migraine such as rovotriptan, naratriptan, and zolmitriptan, and neuromodulation devices. The initial treatment is often a non-specific oral medication. A common treatment approach is to choose from the level A medications based on patient comorbidities and contraindications, then move on to level B and lower levels. An adequate trial requires time to optimize the medication dose, followed by a period of observation to assess its effectiveness. As the onset of the beneficial effect is gradual, this process can require weeks to several months. If the initial non-specific medication fails completely, it is tapered and a medication from a different pharmacological class is initiated. If the initial medication provides partial relief, a second medication is added. Non-specific oral medications are often poorly tolerated. Of patients started on an oral preventive medicine for chronic migraine, only 25% remain on their initial medication after 6 months and 14% at 1 year. The most common reasons for discontinuing such medications are lack of efficacy or poor tolerability, or both. In the 2012 American Academy of Neurology, American Headache Society guidelines for drug treatment of episodic migraine, preventive treatments are rated as follows. Level A, established as effective. Level B, probably effective. Level C, possibly effective. Level U, data inadequate or conflicting. These guidelines have not been revised since 2012, and for some of these medications, more trials since then have established evidence of efficacy. This slide shows how comorbidities in the patient can influence the choice of non-specific oral medications. For patients who are overweight, consider topiramate or venlafaxine and avoid valproate and amitriptyline. For patients who have easy fatigability or exercise intolerance, consider topiramate and venlafaxine and avoid beta blockers amitriptyline and verapamil. For those with cognitive symptoms, consider verapamil, lisinopril, candesartan, venlafaxine, and memantine, and avoid anti-epileptic drugs. For patients complaining of insomnia, consider amitriptyline and melatonin, and avoid memantine. For patients who have anxiety, consider beta blockers and avoid topiramate. For patients who have depression, consider venlafaxine and avoid beta blockers. For patients who have hypertension, consider antihypertensive medications and avoid erenumab, venlafaxine, and duloxetine. For patients with obesity, consider topiramate and avoid valproate and amitriptyline. For patients with a frequent migraine aura, consider verapamil, valproate, magnesium, and topiramate. This slide shows how presence of contraindications influence the choice of drugs. For patients with hypotension, avoid antihypertensive drugs. For patients with nephrolithiasis, avoid topiramate. If patients are likely to become pregnant, consider propranolol, amitriptyline, verapamil, or coenzyme Q10. Avoid valproate, topiramate, lisinopril, and candesartan. For patients with glaucoma, avoid topiramate and amitriptyline. Non-specific oral medications, antidepressant medications. Amitriptyline is one of the oldest drugs used for migraine prevention and was rated as having level B evidence for efficacy in the 2012 guidelines. When started at lower doses and increased slowly, it is typically well tolerated. Nortriptyline is less well studied but often used because of less anticholinergic effects. The SNRI venlafaxine has level B evidence for prevention of migraine but can have a significant withdrawal syndrome. Antihypertensive medications. Propranolol is the most commonly used antihypertensive agent. Metoprolol is cardioselective and also has good evidence for efficacy. Verapamil was rated as level U in the 2012 guidelines, but despite this rating, it is often used. Side effects are relatively benign and the most common is constipation. Verapamil may also be helpful in patients with prolonged migraine aura, migraine with brainstem aura, and hemiplegic migraine. Studies have supported the efficacy of lisinopril and candesartan for migraine prevention. Side effects are relatively mild. This class of medication should be avoided or used in caution in patients who are likely to become pregnant. Anti-epileptic drugs. AEDs tend to have more side effects but may also have greater efficacy. Topiramate has level A evidence and is widely used as a first-line preventive. The most bothersome side effect reported by patients is cognitive slowing, including perceived memory deficits and word-finding difficulties. Sodium valproate is also very effective but has limitations because of side effects including somnolence, weight gain, hair loss, possible hepatotoxicity, and thrombocytopenia. It is also highly teratogenic and must always be avoided in women who could become pregnant. In the 2012 guidelines, gabapentin's efficacy was reported as uncertain, but it continues to be used in practice. Gabapentin may also be particularly helpful for patients with medication overuse headache because it may have both acute and preventive effects. Memantine, an NMDA receptor antagonist approved for the treatment of Alzheimer's disease, has also shown efficacy for migraine prevention in 2 small clinical trials. Several nutraceuticals have been studied for migraine prophylaxis, although none are FDA approved for treatment of migraine. In the 2012 AAN-AHS guidelines, magnesium and vitamin B2 riboflavin have level B evidence for efficacy, and more recent systematic reviews also supported the efficacy of magnesium and riboflavin. Coenzyme Q10 was rated as having level C evidence. Withdrawal of oral agents. Few studies are available to guide decision making regarding withdrawal of non-specific oral agents. One approach is to wait for at least 3 to 6 months of headache freedom before attempting a slow taper of medication.